This is Dr. Ben Weitz with the Rational Wellness Podcast, bringing you the cutting edge information on health and nutrition from the latest scientific research and by interviewing the top experts in the field. Please subscribe to the Rational Wellness Podcast on iTunes and YouTube, and sign up for my free ebook on my website by going to drweitz.com. Let's get started on your road to better health. Hello, Rational Wellness Podcasters. Thank you so much for joining me again today. Dr. Ben Weitz here. And for those of you who enjoy listening to the Rational Wellness Podcast, please go to iTunes and give us a ratings and review so more people can find our Rational Wellness Podcast. Our topic for today is diabetes and pre-diabetes, which are epidemic and increasing in the United States and around the world. 9.4% of adults in the U.S. are diabetic, and in some states, as many as 15%. This equates to about 30 million Americans with diabetes and somewhere around 90 million with pre-diabetes. And these rates are climbing among children and teens. 1 out of 3 Americans have diabetes or pre-diabetes. So, and 90 to 95% of these are type 2 diabetes, which are caused by diet and lifestyle. And rates are even higher among certain population, among American Indians, Blacks, Hispanics, and Asians than among whites. And this is paralleled by an increasing shocking rates of obesity and being overweight, with about 70% of the U.S. population being overweight or obese. And of course, these numbers are pretty much paralleled by the rest of the world, especially as, we spread our American lifestyle around the globe. I'm happy to have Dr. Mona Morstein to join us today to give us some information. She's a naturopathic doctor from Tempe, Arizona, who's practicing functional medicine at Arizona Integrative Medical Solutions, with a focus on treating patients with obesity, diabetes, hormonal imbalances, and gastrointestinal disorders like SIBO and IBS. She's the author of the best-selling book, Master Your Diabetes, a comprehensive integrative approach for both type 1 and type 2 diabetes. She's also the founder and executive director of the Low Carb Diabetes Association. Mona, thank you so much for joining us today.
Thanks very much, Ben. I really appreciate it.
So I'd like to begin the discussion by talking about the different types of diabetes and the distinctions between these.
Yeah, so, there's kind of 4 or 5 main types. There is type 2 diabetes, which is the most common type. It's due to insulin resistance, where usually early on, at least, for sure, people can make insulin, but their cells are no longer responding to the signals to take glucose in. And like you said, there are a number of reasons the cells don't respond, obesity being one of them, but there are other factors involved as well. Type 1 diabetes is an autoimmune disease where a person's own immune system attacks their pancreatic beta cells and destroys it enough so that it cannot produce the insulin that the person needs to live. There's gestational diabetes, which a non-diabetic woman enters pregnancy and then becomes a type 2 diabetic, generally due to gaining too much weight during the pregnancy. There's MODY, mature onset diabetes of youth, which is a diabetes because of gene defects, like the beta cell produces insulin but lacks a good gene to secrete it, or a cell doesn't genetically have a good receptor. And then the last is latent autoimmune diabetes of the adult, which is type 1, that happens in people over 35, say generally 35 to 60 is where we see people getting a less intense type of type 1, but that can still for sure lead to full need of insulin.
Yeah, type 1.5, right? I'd never
Yeah,
heard
type
of that before.
1.5 is yes. Yeah.
Interesting. I think there's some confusion among the general public. I've heard people discuss diabetes and say that type 2s become type 1 once you
Yeah, right. Yeah. So
and
yeah, so we have a couple things. One, we have the lot of patients who are adults getting type 2, very commonly misdiagnosed as type 2. And there's a very simple blood test that can be done. We do have some lean type 2 patients. You will see lean. So we have to make sure, is it really type 2 or do they have LADA? Now, the type 2 becoming type 1, so if you are under poor care and or are not making changes you need to reverse your type 2, if you have bad control of your type 2, the damage that these high blood sugars can cause over the years, it can affect the pancreas as well as, you know, eyes, kidneys, nerves, and heart, you know, the blood vessels. And so people can just, you know, kind of destroy their pancreatic beta cells and this oxidative damage from poorly controlled diabetes, and then as a type 2 need to be on insulin like a type 1.
right. And then type 1 can also have concurrent type 2, right? If they're poorly controlled.
Well, so again, yes, I've seen type 1s coming into my office that, you know, are injecting, you know, 100 or 200 units a day. So for a non-diabetic, say for not a lean, but, you know, normal weight, non-diabetic, so we make maybe around 30 to 40 units of insulin a day for whatever we eat or drink or whatever. So if you have someone walking in the door and they're injecting 100 units a day to control their blood sugar, that's going to cause insulin resistance. That's way above the physiological norm of what the body is designed to have in it all the time. So you can get type 1s that have insulin resistance. Now, a type 1 is going to develop insulin resistance when their blood sugars go over about 170 anyway. Just high blood sugar can make them insulin resistant. So that is a part of it, but it's not the core nature of their condition, which is the autoimmunity.
Right. It's amazing, though, the patients that I've seen, how many are poorly controlled. You know, the kids, they really don't want to prick their finger. They don't want to test their blood sugar. It's a pain. It's, you know, and the type 2s, a lot of them are in denial or, you know, just think everything's okay. And they don't want to test regularly. And so I don't know what the percentages are, but it seems like a lot are uncontrolled.
Well, I know the last statistics we really have in that regard, you know, there was from 2002 to 2006, where almost 75 or so % of people couldn't get below 7, which is the ADA guide. Now,
on the hemoglobin A1C. Yeah.
There's a significant, generally 50 to 60 to sometimes 70, depending on the study, do not attain at least what they consider the 3 ADA goals, which is an A1C less than 7, LDLs less than 100, and blood pressure less than 130/70. So we have very bad, you know, goal reaching in our country. And a lot of it is, of course, due to the obvious, that it's a big pharma-based, you know, treatment, that it's drugs. And those, with type 2, there's only one drug really that was designed to deal with insulin resistance, and that was the TZDs, which, because of a lot of problems with them, have essentially gone off the market. I mean, you can use them, but
what drugs were those? What drugs were those?
Those were the Actos and Avandia type drugs, right? Now, metformin deals a little bit with insulin resistance, but it's not its main job, which is to decrease liver's production of glucose. So you have a disease of insulin resistance and essentially no medications out of the huge list of medications that they give patients that actually deals with insulin resistance. They're all just about clear the glucose out of the bloodstream. And that the way they do that can actually cause quite a number of problems in patients.
Why is that? I guess they've just been unable to develop a drug that controls insulin resistance.
Yes, and or that controls insulin resistance, but again, you've got, it also might cause this or that damage, right? Drugs have side effects, many of them. We're lucky with metformin that it's just some gastrointestinal distress and doesn't really cause anything else. But, some of these other drugs, the second most common one, the sulfonylureas, they cause weight gain, they can aggravate insulin resistance, they can cause hypoglycemia significantly. So, they're all just designed to clear the glucose.
By the way, what drugs are included in the sulfonylureas?
The sulfonylureas are like glyburide, which is the worst for causing hypoglycemia, glimepiride, glibazide, so those kind of drugs, but they're cheap. You can get them for, they're cheap. You can get them for, so they're going to be, by conventional care, another drug to use, but they have problems, right? So and also many of them don't really significantly reduce the A1Cs very much. Like the drugs like Januvia, the DPP4s, they may lower the the A1C like in 3 months at the highest dose of maybe 0.5%, where a low carb diet, could take someone who's at 10 and lower them down to 6 in 3 months. The diet and the lifestyle, there's no drug that equals the amount of improvement that just what we're trying to do on this naturopathic or functional level can do, right?
Right. But that word doesn't seem to have gotten out.
Yeah, well, the ADA, acknowledges there is a low carb diet. It's not like they're saying everybody should, be on it. And, and then, now they're approving bariatric surgery, for people who can't get their A1Cs under control. And, but they can't just come out and say, hey, everybody, everybody really just do the low carb diet.
Right. Yeah, they're still recommending whole grains and the low fat diet.
Well, I went to the ADA site, and, I will say there's a lot of good things about the American Diabetes Association. For one thing, they do devote a lot of money to research, and they have also, if you're a fireman and you're a diabetic, or you're in school and you're a diabetic patient, they've paved the way for the rights, the civil rights and the working rights of people with diabetes, in our country. So, however, to become a sponsor in the ADA, you have to drop at least $100,000. That's the lowest level.
Wow.
So, who aside from drug companies, can be supportive of the ADA, so that's their funding.
Yeah. So let's talk a little bit about type 1 diabetes. Yeah. What are some of the most common triggers? A lot of people have talked about milk as being, milk products as being one of the dairy sensitivity as being one of the triggers. Can you talk about that?
Well, here's the deal. Obviously the number one cause of type 1 diabetes is you have a gene that can turn on and give you type 1 diabetes.
Right.
So it starts from you just randomly got this gene. Now, so then what might be factors turning on the genes? Well, I go through things with every, patient, and, there's questions on vaccinations, on gluten, on dairy, on environmental chemicals, on stress in the families, on nutrient deficiencies. Finland has had like the highest per capita onset of type 1 diabetes. And they've done studies where giving newborns vitamin D and fish oils reduced the onset of type 1 in those populations compared to the kids that didn't get those supplements. So, you know, what is it individually that affects each child? I mean, who knows? We have a lot of kids drinking milk and they're not getting type 1. So we can't say like, oh my goodness. I will say this. I read a good article, a study saying that with, you know, for me, as I noted in my book, if we could identify kids with celiac disease early on, right away, and we got them off of gluten, their risk of developing type 1 would go down about to 0. You know, but, you know, we've got all these pediatricians, you know, giving them antibiotics to their ears or vaccinations, whatever, but we need to get them to screen like every child who's now eating gluten, because you have to be eating gluten. So toddlers, a 2-year-old, right? Test them for celiac disease before potentially it's unknown. And then we get kids, you know, developing type 1 diabetes, since those two are so connected. So, but
by the way, what's the proper test for celiac?
So the proper test for celiac in a child is you can do a stool sample for toddlers, right? There is also a blood test, as a pediatric blood test. But people, you know, you have to be eating gluten every day, like the equivalent of about a piece of bread for at least 3 to 4 weeks before the test. Otherwise, we can't see if there's celiac disease. So
unless you do an intestinal biopsy.
Well, they're gonna do that after the blood draw, right? Yeah. But we've got a lot of kids. I see kids, they never had they never had a vaccine. The parents ate, you know, they're very loving family. There was no stress, like a pet dying or grandma, God forbid. You know, they didn't, they don't spray they don't have an exterminator come into their house or outside. And you're just like, why did this happen? And we just don't know. We can't identify it on each individual.
Right. I noticed in your book, you mentioned the A1 milk being more problematic than A2 milk.
Yeah. So I think most people understand, or not most people, but, you know, the milk in America, you know, that A1 milk is from cows that have a different amino acid basis to the protein molecule of milk. And that is more allergic in humans, versus many other countries in the world use cows that make what's called the A2 milk that has a different amino acid. It's very less reactive. So our milk is why, you know, we certainly see many people have at least a cow's milk sensitivity, which can be a lot of mucus and sinus and asthma, or it's the number one food that causes GERD, reflux, even without mucus. It just goes right to the stomach. So, you know, and those are from the allergy to the milk protein. Lactose intolerance, you just can't digest the lactose. That'd be A1 or A2. But in terms of allergic to milk, and there is some connections. If you have that allergic to milk, there are some similar proteins on the pancreatic cells that are, so if the immune system is kind of attacking the milk, it could get confused and maybe attack the similar proteins on the pancreas. I do want to mention one thing, though. When we talk about food sensitivities, or just in general, we're talking about oftentimes leaky gut. And what's interesting with leaky gut is that when kids have diabetic antibodies but are not yet showing the disease, they pick up an upregulated zonulin. They show leaky gut in these kids. And another reason people might get type 1 is a virus getting through the gut wall and then attacking the pancreatic beta cells and causing damage to them. So we look at the gut quite a lot. And if you're getting into food sensitivities, we're going to think your gut is unhealthy as well, since it all comes from the gut. But leaky gut seems to precede type 1 diabetes in many kids.
And that's interesting because we've heard about the research from Alessio Fasano, who talks about this triad of autoimmune disease where you have a leaky gut and then you have gluten, and then you create this upregulated immune system, and that sets up the potential for autoimmune disease.
Yeah, although I will differ in one regard. I know there's a very big anti-gluten, anti-dairy, but for those of us like myself who does a lot of food sensitivity testing, some people are sensitive to corn, and some to soy, and some to eggs, and some to almonds. And I think, before we just pull everybody off of, and not everybody actually reacts to gluten. So I really think that we should always strive to do very individual care with the food sensitivities and really see what is their body reacting to.
One of the problems is these food sensitivity testing is so problematic. Sometimes you do a test and you seem to get reasonable results, and then you do a test and like nothing comes up except clams and some other bizarre food which they've never eaten, and now you spend all this money for this test and nothing comes up, or
well, I would say
and everything comes up.
So. Well, so everything coming up obviously is a sign of leaky gut, but I think there's a lot of labs doing food sensitivity, but I don't know the quality. I know the lab I use. I've flown out there. I visited their lab. I can verify the one I use for the last 16 years has been, which is Alites Labs at foodallergy.com. They must have got that right at the beginning of the web. So I can verify their consistency with truly finding what people seem to be reactive to. And if people have a lot of foods, here's the idea with food sensitivities, you take them all out the first month, start healing their gut with the supplements, and then they come back in a month and they should be significantly better. And then you can start adding the foods back in. Nobody has to be off all of these foods for a year or two or whatever. It's an indication of something needs to be healed, but guts heal from leaky gut enormously quickly when the irritant is removed because they're so vascularized.
Yeah, I just want to point out, I just had a discussion with Cyrex where I had one of these tests come back where there was nothing tested. And they said, from now on, we can include a total IgG with the test at no additional cost. And that way you can tell if the person's immune system just isn't working well, and their total IgG is suppressed, then they can factor that in and recalculate the results. And
I guess there's also cheaper tests than Cyrex.
So you mentioned vaccines as triggers as possible triggers for type 1 diabetes. And I noticed in your book you mentioned giving the kids some supplements to help with their immune system, like you mentioned vitamin D and echinacea and milk thistle.
Yeah, so when I was in medical school, we had a pediatrician come and say, hey, when I have to give antibiotics or I have to give vaccinations, I'm boosting their immune system a couple days before, during, a couple days after. And so that obviously made great sense to us because we don't usually get exposed to viruses by injection. We breathe them in. And then it takes days for the process to happen. So it's a little bit of a shock to the immune system. I think, giving NHC, there are kids that maybe can't make glutathione that might get as well, that might get some nerve damage. So doing I do a product called Imugen from a company called Progena because it's glycerin. Kids love it, but it's a great immune system booster. And D and, maybe some liposomal. Now I give, glutathione because kids can't really take, obviously, an NAC capsule and it's nasty flavor-wise. So, by giving some ways to support antioxidant status, immune status. It can really, I hope, seem to boost things in the kids so they don't have a really serious reaction against the vaccine, not only just against the vaccination, but the liver is just part of the excipients. They have a good website where the CDC lists, all the excipients in all of the vaccinations. And so that's what we're trying to have the liver clear better, is that junk that it comes with, the virus they're injecting.
Yeah, the World Health Organization actually recommends giving 200,000 IUs of vitamin A prior to the MMR vaccine.
And they came out 25 years ago saying they're very much into 2,000 units of vitamin A, also for treatment. If someone has measles, they said, hey, give them 200,000 vitamin A as this huge immune booster. And so I've used that in many conditions in toddlers who were pretty sick. Of course, I do it maybe for 3 days or 4 days, but vitamin A is cheap, and the World Health Organization can use it in rural villages. It's easy. It's a huge immune booster. I would just give a clinical pearl. Don't give it all at one time. If it overwhelms the kid, they can have a really nasty headache. So you want to break it up into several doses throughout the day, and that should stave off the headache that can last for a few hours with acute elevated vitamin A.
Yeah, I've never liked the idea of giving one huge bolus. Same thing with the 20,000 or 50,000 injectable vitamin D. It seems to make so much more sense to give 5 or 10,000 a day over the course of a week than give them a 50,000 unit shot.
Yeah, well, shots are a little rough anyway. With vitamin D. It's oily. It's hard.
So moving on to type 2 diabetes and the mechanism for type 2. Most of us are aware of the fact that eating sugar and lack of exercise are, some of the main factors because we've got this rising blood sugar and insulin resistance. But I read in your book that you also said that increased saturated fat intake can play a role.
Yeah, I mean, I know there's a lot of, ketogenic and et cetera, paleo people out there, but the science is pretty clear that if you're getting too many saturated fats, and I believe it's too many saturated fats unopposed by a good amount of omega-3 fats. Omega-3 fats lower insulin resistance. Saturated fat, if you're getting too many, they can absolutely worsen insulin resistance. And so the idea is not that you can't eat saturated fats, but that we have got to make sure people are, getting into their diet a balance of the omega-3 oils for sure. And if you get, even with meat, if you get grass-fed, grass-finished, organic meat, half of that is essential fatty acids. But if you're getting it, you're just lazy or you're going out to eat a lot, that's feedlot meat. That has no omega-3s. After 90 days of being fed grains, that meat has no omega-3s left in it. So this can be throwing people off with their oil balance.
Interesting. Yeah, it's true with the paleo movement and the ketogenic movement. There's a big push for saying that saturated fat is perfectly fine. And a lot of people are sort of like, can it really be fine? I mean, should we really have as much butter as you can consume? And then, of course, there's the fat with sugar problem, that I think Mark Hyman calls sweet fat, that's really the bad combination, is when they're eating junk food and they're getting the saturated fat with the high glycemic carbs, sugar, combination.
Yeah, I mean, it's certainly, it's certainly refined sugar, refined grains, junk food, fast food. But I mean, if you just want to overeat anything, gluttony, unfortunately, is just whatever you're overeating to gain that abdominal fat, is going to be a problem. And of course, the problem with insulin resistance is once it sets in, insulin is one of the hormones that tells your brain, I'm full, I'm done, that's enough, that's it. I don't need to eat more. And you can get that insulin resistance in the brain can tell people I'm still hungry, I still want food. And so it's not lack of willpower, it's literally our appetite is driven by chemicals and hormones, and when they're thrown off, we're just not going to get signals that I'm done, that's enough, walk away from the table. And so once people get, say, on a low carb diet, in a week, they're like, oh my God, you know, it's easy. I can just eat a piece of fish and this, I'm full, because that can settle down in their brains very quickly when they, through food, when we get that under control. But, you know, it's whatever you're overeating to become overweight, or drinking, of course, soda pop, you know, energy drinks, these sugary things, they're just really some of the worst, right?
Yeah. Even Gatorade and some of the things
Yeah.
that people think are healthy. So when it comes to lab testing, what labs do you like to run for patients with either pre-diabetes or diabetes?
Well, obviously people need to have their yearly with the liver and kidney and glucose and the lipids and their CBC. I always include ferritin, which is not standard on labs. Not just ferritin has three different has three different roles in the body. One is storage iron. Two, it's we store it when there's a bacterial infection, a serious bacterial infection. And three, it's a acute phase inflammatory marker. And if we have a type 2 who's got elevated ferritin, while you do maybe have to rule out a condition called hemochromatosis, which is a genetic hyperabsorption of iron from your food, mostly these people have fatty liver. And so we need to do then an ultrasound of their liver, and we can pick up fatty liver. And that really drives insulin resistance, and fatty liver is the #1 chronic disease of the liver in our country today, and can cause the same kind of fibrosis and cirrhosis that alcoholism does.
And it's really caused by sugar and high glycemic carb intake, right?
Well, it's just caused by too much fat, really, whatever caused the fat. The abdominal fat will then go and get to the liver and cause the liver to have now too much fat in its cells. Of course, an A1C, a C-peptide. So you can draw insulin to see how much insulin they make, as long as they've never injected insulin. As soon as someone's injected insulin, you can't measure it anymore. It's an inaccurate reading, because as soon as you inject insulin, you'll make insulin antibodies. And so C-peptide is the part of the insulin molecule that breaks away from it to actually form insulin. So they're equal. There's one C-peptide for one insulin, but we never make antibodies to C-peptide. So that tells us what is your pancreas able to produce in terms of insulin. There's another test called glycomark, which is a 1,5-Ag substance that helps us look at excursions and sometimes interpret the A1C better, because you can have an A1C at 6 because you're having lows all the time.
By the way, for those who don't know, hemoglobin A1C is believed to be like a 3-month indicator of blood glucose levels, right?
The A1C is our monitor, how you're doing long term. And it can be, it could be the same number of the A1C can be there if you're under good control or if you're just going up and down all the time. So the glycomark can help us interpret that. I do vitamin D. We might need to check thyroid. We might need, for guys, we might want to check their testosterone levels. There's just maybe some red blood cell magnesium, red blood cell zinc. These can be low in people with diabetes. So some of the, I would want to do an HSCRP, which is a monitor of inflammation that's related to cardiac disease, and a fibrinogen to see how clotty they are, just because they have people with diabetes type 2, especially, well, if it's not well controlled, have a very high increased risk of dying of cardiovascular disease, which is basically what they usually die from. So these are, this broad-based labs that we'll want to do.
Cool. Do you include adiponectin and leptin in your labs?
I don't do either of those. For one thing, leptin, there is a leptin resistance or adiponectin. Those are going to be fixed when you fix their weight. When you fix it, so to measure them, we don't really have any specific ways, I feel, that's really effective in that. And those will readjust once the insulin resistance is settled down. Cool. I did want one other lab, the random microalbuminuria. That's a good urine test to pick up early liver damage. And before it shows up in the lab work. But no, I don't measure those hormones.
Okay, cool. So let's talk about treatment.
Yeah.
So what type of diet is best for diabetics and pre-diabetics?
Well, Dr. Richard Feynman and Dr. Richard Bernstein, and 25 other physicians or researchers came out with an article that was printed in Elsevier journal on that. A low-carb diet is the premier treatment for people with type 2 diabetes. And actually, other researchers just came out showing that type 1 diabetes pediatric patients were improved on a low-carb diet, plus 1,000 other studies. So in some way, now you've got, you've got two, you do have the MAPI-1 study, which showed that people on a macrobiotic diet that was higher carbs, but no animal fat at all, no real oils at all, actually was very significant in uncontrolled type 2 diabetic men at really reducing everything we wanted to have reduced. So you get some people that are saying, a plant-based diet, higher carb. But for most people, it's got to be low carb. And, in our society, honestly, people are going to thrive much better in our society and be able to socialize and eat out and on a low carb diet than they will on some macrobiotic, diet. So the low carb can be this, what I call the omnivore low carb, where you eat some meat and fish and some organic soy, and you make things out of nut flours and coconut and, eggs, just all around variety. You eat nuts, or there's the keto aspect, which is very, very low carb, or there's actually a vegan type of low carb, and then there's an ovo-lacto vegetarian type of low carb. So for my patients, in reality, most of them don't want to do keto, and I don't make them, and I don't think you need to, but they do that, that 30 to 40 grams a day of carbs, which will work very well for almost everybody. But it gives them a little more food to eat, almond muffins or pancakes and, things that make life more enjoyable for most people eating low carb.
Do you let them include any whole grains or legumes?
No, I don't know. The grains, you can't do any grains.
What about legumes?
Yeah, legumes, no, you can't. Now, every now and then I have a couple patients who are in really great control. And if they have a couple tablespoons of hummus, because there's got oil in it and it's got the garlic in it, they say that, a little hummus doesn't bother them. Okay. But no, beans and grains and potatoes and sweet potatoes.
Beans are so high in fiber, right?
Yeah.
And their glycemic index is like, in the 20s.
You would think with the beans it would work, but for my patients, eating beans, they're going to go up. Now they might come down after just an hour or two, say, but it's tough. The beans are incredibly high in fiber. In fact, for a non-diabetic patient, I'm not an advocate of keto or paleo at all. And there are studies where these changes in the microbiome by not eating grains or not eating beans in non-diabetic patients, just as a general diet, are devastating to the microbiome. And because the microbiome, the beneficial bacteria, eat fiber. And so when we take out these great sources of fiber, we change the bacteria. We start making less short-chain fatty acids, and that's not a good thing for colon cells or even systemically. So on a low-carb diet, I'm very adamant that my patients have to add fiber powder back in. If you're on low carb, you have got to be getting at least 5 to 10 grams of fiber powder in a day to make up what we're taking out, because vegetables just really won't do it enough.
Yeah, and of course, whole grains are also high in fiber too, which, that makes it harder to get the fiber.
Yeah, I mean, for people that are, non-diabetic, to eat whole grains and to eat beans, I am an advocate of that as well, for sure. But once you become a patient with diabetes, you can't do it anymore. So at least with supplements, we've got to replace both water soluble and water insoluble, that balance of fiber, at least into the diet, while having them eat a healthy diet otherwise.
I notice you recommend no snacking. And, for years, we've always recommended snacking. You don't want to go too long or your blood sugar will dip. So every 2 to 3 hours, you have to have some, food in your system to keep an even blood sugar. And that theory seems to be gone, huh?
Well, it's gone in me. I mean, I have from day one in medicine, which is about 30 years ago, I've always been an anti-grazer. Even for, hypoglycemia, you have to eat many meals throughout the day. That's called enabling the condition.
Yeah, but grazing is different than snacking. Like say, here I'm going to have 12 almonds as a snack or something at, 3 o'clock.
I mean, if you just want a snack, but the question is that the human organism easily has the capacity to not eat for 5 hours. We're not like, we can, I eat the breakfast and I go hike 10 miles without eating. That's what the human organism can do, right? So this idea, like, we cannot go from breakfast to lunch and from lunch to supper and then from supper to breakfast, we can't do that physiologically. This was just wrong. And so, we want, at least in terms of intermittent fasting, at least from breakfast, from dinner to breakfast, at least 12 hours. Right now, you want to go 16, whatever, we can, there's other ways of doing intermittent fasting, but we have got to teach people that have trust in your body, eat that, eat a decent meal, and then don't eat for 5 or 6 hours, and you're going to be fine. And not only that, now you don't have to think about eating. And now, your adrenals aren't stressed and your liver isn't stressed. And, what I tell patients, when we're measuring your heart rate, right, or when we're measuring your blood pressure, the first number is when it's beating and the second number is when it's at rest. And the second number is really the number we're really interested in, right? Because that heart needs to rest. And you know what? Your gut needs to rest as well. It does not want to be digesting food all the time. You don't want to be active all the time. You need your sleep. You need to rest. So think of your gut as any other part of your system that needs rest, right? And that means it doesn't have to digest all the time. And, in fact, fasting is the healthiest thing a human can do to get over an illness, a chronic illness. That's not eating at all. It's putting your gut totally at rest. So, we just have to retrain people, and especially people who are injecting insulin, snacking. Well, how are you that's going to screw up your insulin totally. So, yeah, I'm a very big anti-grazer for everybody.
When it comes to intermittent fasting, I just think it's so ironic because, I've been involved with healthcare and nutrition for 30 years. And I know when we got started, the biggest thing was You have to eat breakfast. You have to eat within a certain period of time. Everybody's skipping breakfast, and they're running out of the house, and that's why they're fat, because they eat too much at dinner because they didn't eat breakfast. And you have to eat breakfast because that gets your metabolism going. And so that was so important. And now the big trend is, if you want to be healthy, you got to skip breakfast.
Well, not me, but
Okay.
that is for I eat breakfast. I'm breakfast, lunch, and supper. So we have to learn, everybody, but maybe
that's how a lot of people do the intermittent fasting.
Yeah, they do. I mean, I do fast from supper to breakfast, but I like breakfast.
No, I'm with you on that. I prefer to skip dinner if I'm going to skip a meal, but
I know. So, here's the deal. We have, unfortunately, right now on planet Earth, we have extremism all over the place with politics and whatever, this and that. And it's certainly
planet Trump now.
Well, yeah, it's certainly entered into nutrition too. And I think what we have to realize is that there isn't one way that everybody is going to thrive eating. And so our jobs with functional naturopathic medicine is, what does this person need for their health? Me, I like breakfast and I work better with it. But other people, especially if you have weight to lose and so forth, doing a longer fast is great. And working out where you don't have food in you can burn more fat. So if it works for them and they can do it, I mean, these are good ways to consider. But we just have to not make rules that everybody has to eat this way. And unfortunately, we get too many docs that say, I eat this way, so now everybody has to eat this way. And that's the exact opposite of the beauty of, say, functional medicine, where we're supposed to be looking at each individual.
Right. And individualizing the program for their specific physiology and their needs and the way their body works.
Exactly.
So for the final section here, I'd like to talk about supplements that can be a benefit for patients with diabetes or pre-diabetes.
Yeah. Now, just to get out of the way, I have a proprietary formula called Diamend from Priority One, which I think is a really good product. It's in one bottle. You get everything you need at therapeutic doses. But when we're talking supplements, people with diabetes say everybody needs to be on a good multiple vitamin, and a good one, like maybe you're taking 6 a day, that gets in all of the basic nutrients. So we know that you're getting in everything you need to have your body work well, and antioxidants and nutrients that help your organs, your liver, your adrenals work better, and help you become less insulin resistant, which is zinc and chromium and vanadium and so forth. And it's just easy to get it in one good package. Then
I know you mentioned therapeutic levels, and you talked in your book about how you can take some one-a-day vitamin.
Oh, yeah.
It has these ingredients that people are reading about in the latest news story, but they're in trace levels that are going to be insignificant. If you're going to take a specific nutrient like chromium or lipoic acid or some of these others, it's got to be a therapeutic level, or you're kidding yourself.
That's an excellent point. And that's why, I think docs like us because we can have patients bring their supplements in. We know how to read the label, see if it is a valid supplement at good doses for what they need or not. And like with fish oils, I'm not an advocate of krill oil, right? Because when you see the amount of EPA and DHA,
it's a joke.
It's a joke. It's a total joke. So
24 milligrams of EPA and 30 of DHA.
Exactly. But people have heard it's this, it's krill oil, so you're paying twice as much for a useless therapeutic EPA DHA product. So
you'd have to take 20 of those capsules to get 2 grams of EPA and DHA.
Exactly. Thank you. So we need to get, I am a big advocate of quality fish oils, just like you said. And then there are supplements that, diabetes damage is oxidative damage. There's several different pathways that happens through, but it's oxidative damage. So we need supplements that help reduce insulin resistance and that help protect the body, so that even if their A1C isn't at 5.1, they're still, because an A1C over 5.5 and certainly over 6 is indicating by science it's causing damage to the human body. So, and that damage is oxidative. So we've got to get, and you've got some supplements like alpha lipoic acid or N-acetylcysteine. They're not just antioxidants, but they reduce insulin resistance, right? And they both help the liver. And most patients who are type 2 diabetic and overweight have fatty liver. So, you can get some nutrients that really have a very big crossover benefit in several ways to the body, right?
By the way, in your book, when you talked about lipoic acid, you mentioned something that I think most people are not aware of, which is that there's a difference between lipoic acid, which is commonly seen on the market, and R-alpha lipoic acid. Can you talk about what the R form means and the difference?
Right. So there's two different isomers or chemical ways it presents alpha lipoic acid.
We usually think of DNL forms, but
that's with vitamin E, of course. Certainly just right. But with yes, exactly, DNL, and that's with phenylalanine as well as a DL. So. Right. But in alpha lipoic acid, there's the R and the S isomer. The S isomer is not active in the body. And in fact, they say it may even interfere a little bit with the R. Only the R isomer is active in the body. And if your bottle just says alpha lipoic acid, half of it is R and half of it is S. And so about 20 years ago, companies figured out a way to make just R and have it be stable. And so that if you've got alpha lipoic acid 600, only 300 of it is the R. If it says R alpha lipoic acid 600, you've got a double effect. So we prefer just the R's when we're working with our patients. And of course, berberine, right?
By the way, what's a therapeutic dosage for R lipoic acid?
I would say orally, if you're getting around 600 milligrams a day. There's a very, very rare side effect I've only seen in 2 patients in 30 years, which is it can burn the stomach. But I mean, for the literally hundreds and hundreds and hundreds of thousand people that I've put on alpha lipoic acid, it's very rare. But you certainly can't open the molecule and drink it down. It's an acid, so it does have to be swallowed in a capsule. Little kids, can't take it until they can swallow a capsule.
Okay, I'm sorry. Keep going.
No, I was just saying, we mentioned berberine.
Yeah.
Had that great study comparing it to metformin.
Right.
Where it showed so we like berberine. It can upset some stomachs, but if you give 1,000 or 1,500, most people can handle that. Also, a very good liver herb as well. So that's another good product to consider.
Okay.
We've got the blueberry, bilberries for the eyes, green tea extract was shown to help the pancreas. So there's
you got benfotiamine, which is the fat soluble form.
Yes, benfotiamine, very excellent, shown in studies for nerve damage, kidney damage, eye damage. And of course, that and the endothelial lining are the 4 areas where diabetes has its most effects, because those cells cannot prevent glucose from entering them. Insulin resistance does not affect those cells. So if your blood sugar is 300, your eyeballs are 300, and your kidney is 300, and your nerves are 300, and your endothelial lining, your blood vessels. So this is why those degenerate so commonly in people with diabetes. But benfotiamine, around the max dose is around 450 milligrams a day. Very good, safe product. And ironically, we usually think fat solubles are harder to absorb than water solubles, but with benfotiamine, it's actually better absorbed than water soluble thiamine.
Cool. And in your book, you also talk about L-carnosine.
Yeah.
Which can reduce glycosylation.
Yeah, I actually don't use it too much.
Okay.
But yes, I think I learned about that from another physician years ago, and there are some studies supporting that. But to me, also vitamin E might be able to do that. But I just think if we're getting the person under better control, then that should lower, and it does, all the glycosylation throughout their body. We think of it as the A1C, but it can also fat and protein. It's a fat and protein reaction, the Maillard reaction. And that can happen in joints and tendons. People with diabetes can get more into injuries and frozen shoulders until they're, when their blood sugars and A1Cs are higher, because that's happening throughout their body, not just on their red blood cells where we can measure the A1C.
How about cinnamon?
Yeah, cinnamon is, there's a type of cinnamon that was shown in studies to help lower blood sugars.
Which type of cinnamon is that?
The Birmani type of cinnamon. And so it tastes good, and it's good in the fall when it's getting cold. And so cinnamon is another. Some patients take cinnamon, like some capsules at bedtime, and they say it can help lower their morning glucose. So it's a pretty benign substance. It's 1,000 milligrams was they did studies on 1,000, 3,000, 6, but even the 1,000 might be beneficial, or just using it as a spice on your food. Curcumin, of course, as an anti-inflammatory. We do know that the tummy, fat makes tumor necrosis factor alpha. It makes interleukins. These can go to cells that cause insulin resistance. And so decreasing inflammation via fish oils and curcumin and can all be helpful to patients. Also, we do know this association with Alzheimer's and people who have had poorly controlled diabetes, and curcumin has been shown to help reduce the risk of Alzheimer's. There was a good study in India that people eating more curcumin had less risk of developing Alzheimer's. So again, and it's also a good herb for the liver. So these things, again, have really good crossover for our patients.
You talk about fiber and the need for fiber. What do you think about some of the resistant starch supplements on the market? And they have medical foods with resistant starches.
Yeah. I mean, I've tried those and never really saw they did too much. And, historically, there were bars that were given to kids at nighttime to prevent them from having lows during the night. But, kids on insulin don't have to have lows during the night if they're on a low-carb diet. And so it's not like, in conventional care, eating whatever you want and covering it with insulin is the axiom of treatment, and that's going to cause all kind of highs and lows. But in terms of, did I see real clinical benefits to resistant starch? I honestly didn't. And, I don't, and if people are just eating correctly, that's going to work for so many people. So I mention it in the book because people think about it. I haven't seen it clinically that a helpful an addition.
And you also mentioned the herb Gymnema sylvestre.
Yeah, I should have mentioned that earlier. Gymnema sylvestre is my favorite botanical. There's that and bitter melon as kind of two, but I love Gymnema sylvestre. The studies have used 400 milligrams, but I've gone up to, with some patients, I've gone up to 2,000 or 2,400. Gymnema sylvestre has been shown to help the pancreas produce insulin again, and it also reduces the risk. It reduces cravings for sugar. In a tincture form, it's pretty amazing that if you put a tincture of Gymnema sylvestre in your mouth and swish it around for a minute and then swallow it, you can't taste anything sweet. It's disgusting. You can't eat it. So for some patients that are still working, the holiday times and going to parties, I'll give them a little 1 ounce bottle and say, just take this before you go to the party. Then try to eat that cookie. You're going to spit it out because it's just going to be nothing in your mouth. And it's really an amazing, way to go. It just numbs the sweet taste for about an hour or hour and a half.
That's great. That's a
Yeah.
great hint. So I know we both have patience and we got to go. So let's make this a wrap here. So for listeners who want to get a hold of you, what's the best way for them to contact you and to get a hold of your book?
Yeah. So my book, the short name is Master Your Diabetes. It's up on Amazon. Dr. Morstein, Morstein, Master Your Diabetes. And my website is Dr. Mona Morstein, Morstein. And from there, I'm in Tempe, Arizona. I do telemedicine as well. So check out my website and give a call if you are interested.
That's great. Dr. Morstein, thank you so much for this interview.
Thank you very much, Dr. Weitz.